Next, this is the easiest question. Isovolumetric relaxation ends up with relaxing. You're relaxing your ventricles, so it must be the time for the filling. Upar, the atria is going to be there on the top, ventricle is there in the bottom, right? The atrioventricular valve will be closed. As soon as you decrease the pressure in the ventricle, the valve will be opened and the atria start filling the ventricle. So A, B valve is going to be opened, right? Very, very easy. I hope everybody got this correct. Okay. So C wave is because of what thing? C wave is because of isovolumetric contraction. It is not because of isovolumetric relaxation. IVR, that is isovolumetric contraction, is going to be isovolumetric contraction is going to caused by, yes, which wave it is going to give? It is going to give me V wave in the JVP, not the C wave, right? Beginning of the T wave. No, T wave will begin before the isovolumetric relaxation, not, it is not going to end in the isovolumetric relaxation. Relaxation is the mechanical phenomena, remember. Before that, the T wave is going to end. Closure of the semilunar valve will occur even before the isovolumetric relaxation has been started, S2 to S1, right? It is not going to end with that. So answer over here is going to be option B. This is the easiest one. Whomsoever has done the mistake in this question, pack your bags. It's that time to send you on the bridges, right? So what is this? Cardiovascular reflexes which were given over here and incorrectly match, which you have to identify. So Bezold-Jarisch, when you give bizarre things in the blood, the respiratory system and the cardiovascular system say shh for some time. That means the respiratory rate is going to decrease, the BP is going to decrease, even the heart rate is going to sorry, over here it should be heart rate, and the apnea, that means respiratory rate is also going to decrease. And yes, it is because of the vagus. So this is correct. It is not incorrect. Bainbridge, I told you, if the bridge wala reflex is there, it is the only reflex, only bridge reflex can cause tachycardia via stimulation of SA node, right? Yes, it is going to cause venous return to be increased, but that is going to cause tachy, not brady. This is incorrect. So they have asked us incorrectly match. So this is incorrectly matched. Cushing's reflex, confusing reflex, because of the increase in the ICT, which is going to cause hypoxia to the brain, and because of the cerebral ischemia involving hypertension and bradycardia. Confusing. So heart rate cannot increase, heart rate will be decreased, and the BP will be increased, right? So this is true. J reflex is the twin brother of the Bezold-Jarisch in the respiratory system. Bezold-Jarisch, cardiac reflexes. J reflex, mainly the respiratory reflex, which is going to cause bradycardia, hypotension, apnea due to JP, that is juxtapulmonary capillaries receptor, right? So J receptor, juxtacapillary receptors, right? So option A. Option B is going to be the answer over here. A is the twin brother of the option D, right? Chalo, let's move on. This was the easiest one. I hope everybody got this Bridgewala reflex at least right. Next, mean blood pressure less than 60 mmHg is detected by. Now, there are two things. If it is more than 60 mmHg, 60 or more, it is going to be the baroreceptors which are going to kick in, right? And if it is less than 60, 40 to 60 mmHg, it is going to be the chemoreceptor. The mean blood pressure is already low, so you have to activate the accelerators. So chemoreceptors act as an accelerator, and they're going to activate the sympathetic system. Baroreceptors, they act as a brake to the system, and brakes are going to pulled up by activating the parasympathetic system. That is nothing but your CIC or CVC. CIC is cardio inhibitory center or cardiovagal center. This chemoreceptor is going to be your VMC, vasomotor center. Now the pressure has been lowered down, so I'm going to go with the chemoreceptors, not the baroreceptor or pain receptor. Even if you know that, you will get to the answer. And yes, it is going to activate sympathetic system, not the parasympathetic system. Nausea means noxious. Noxious means harmful. So that is nothing but the painful or harmful receptor. Nociceptors are pain receptor. So pain receptor will never be activated because of the low blood pressure. Please remember that. All right. So it is going to be your, yes, please. It is going to be the option B, which is going to be the answer over here. चलिए next आगे बढ़ते हैं. to the next question. A 66-year-old man has a history. All right. 66-year-old man has a history. Worsening exertional dyspnea. All right. So suspect turbulent blood flow across the narrowed valve, and which of the following parameter, if increased, would most significantly decrease the Reynolds number? So they have given turbulence is nothing but Reynolds number. Now, what is the formula for Reynolds number? Formula for Reynolds number is going to be rho dV by eta. Rho dV, if you increase the Reynolds number will increase. If you increase the eta, which is nothing but the viscosity, the Reynolds number will decrease because that is present in the denominator. Denominator is always inversely proportional to the ratio. So please remember, only when you decrease the eta, which is nothing but the viscosity, blood viscosity is going to be the answer. Why? Because they're asking if increase, that is going to decrease the Reynolds number, right? So as simple as that, the rho means rho dV. This is the diameter, this is the density, right? Rho means density, this is diameter, this is the velocity, which is the most important factor. But when they are going to be increased, it will increase the Reynolds number. Answer over here is option A. Next, which of the following condition is most likely associated with the leftward shift or shift in the pressure volume loop? So this is the normal loop that which have been shown over here. I told you, whenever there is going to be the right shift, okay? So right shift means kya hoga? Let's say the shift was like this, okay? So if there is a right shift, either in this format or in this format, in both the condition, if there is a right shift which you can see, then it must be the regurgitation condition. Why regurgitation? In any of the regurgitation, aortic regurgitation or even in the mitral regurgitation, you're going to have more EDV left in the next cycle. So please remember, if it is a right shift, means it is regurgitation. But is it talking about the right shift? Yeah, no, rather it is talking about left shift, or slightly you can see that it has been going towards the left. It is not a proper left shift, but what one more thing that you have to focus on, I told you that this is going to be the regurgitation. Then you have to check for whether you are increasing the afterload of the patient or not. See over here, afterload. How I can identify the afterload? Afterload will be identified via the left ventricular pressure, increment in the left ventricular pressure. So if the increment is much more, the pressure is rising a lot, so that means the afterload has been increased, right? So in these two conditions, this is the purple color graph is of regurgitation. So whenever the afterload increases, means graph goes upward. So please remember, it is going to be the aortic condition that is going to be there. It is not a regurgitation because it is not a right shift. So if it is not a right shift, that means it is not a regurgitation condition, and it is the stenosis condition. It is the stenosis condition. And since the afterload has been increased, afterload will be increased. Though there is a right shift or not right shift, if the afterload is increasing, it is going to be the aortic condition. Why? Because the heart has to, mainly the ventricle has to push the blood towards the aorta. And if the aorta has stenosis, it is going to increase the afterload. Even the regurgitant is coming from the aorta, it is also going to increase the afterload on my ventricle. So please remember, it is going to be the aortic stenosis condition and not any regurgitation condition. Congestive heart failure where the afterload is going to be much lesser because the heart has failed now, right? So please remember, it is going to be aortic stenosis. Just remember whether there is a right shift or not. If there is a right shift, regurgitation. No right shift, no regurgitation. Stenosis. If the afterload is increased, aortic condition, right? It is not a mitral condition. Easy. Next, stimulating the cephalic end of the vagus nerve would causes the respiration too. Now, what is the role of vagus nerve? Vagus nerve goes from the stretch receptors of the lungs, and it is going to go and inhibit the apneustic center. What is the role of apneustic center, by the way? The role of apneustic center is to stimulate the DRG, and it controls the depth of the respiration by activating DRG, which is going to have the I neurons, which is inspiratory neurons. I neurons or inspiratory neurons, the DRG will be stimulating the inspiration more. If I'm inhibiting, I'm stimulating the vagus more and more. I'm stimulating the vagus more and more. That means it is going to inhibit the apneustic center more and more. It will not be able to stimulate my DRG. That means the depth of the respiration will be decreased. Depth of the respiration is going to decrease. So what is the answer? Decreased depth because of the lung stretch receptors. That is true. Increase in the rate. Rate is controlled by the pneumotaxic center. And the vagus has no communication with the pneumotaxic center. So it is not going to affect the rate of the respiration. Increase in the depth? No, it is not going to increase the depth. Please remember, it is going to decrease the depth because of the stimulation of you can say vagus, which is going to cause the apneustic center to be inhibited more and more. So it will not be acted upon, and that's why the depth is going to be decreased. So option A is going to be the correct answer over here. चलो आगे बढ़े. Next, a 45-year-old man is undergoing pulmonary function testing during the test. He has to sit quietly. Okay, nothing to be done. Breathe normally without any force or forced effort. Right? Following muscle primarily act during the expiratory phase of quiet breathing. What was the answer? What was the answer that you have given? Very good. No muscle is required. Expiration in the resting condition or quiet breathing is passive. Whatever muscle you have contracted during the inspiration, you just have to relax them. All right. So rectus abdominis, yes, it is going to help me out, but during the forceful expiration, but they're asking about resting. So it is going to be the option D, which is going to be the answer. External intercostal helps me in the inspiration. So it has no relation with the expiration. Internal intercostal rectus abdominis, they're going to help me out in the forced expiration. Over here, they're asking about the quiet ones. So quiet one, right? And forceful inspiration, you're going to have the sternocleidomastoid and scalene muscles, which are going to help us out. So it is going to be the resting or quiet expiration that we have asked about. So it is going to be none of the above. Next, all of the following can be seen in the lower motor neuron lesion. I told you, upper motor neuron, lower motor neuron. Lower motor neuron has two babies. That is alpha motor neuron, that is acha bacha, right? And gamma motor neuron, which is gadda bacha, right? So alpha motor, upper motor neuron, they are going to be like parents. They are going to promote or stimulate the acha bacha more, and they're going to punish the you can say naughty kid, right? Gamma motor neuron, ganda bacha. So the alpha motor neuron is important for me for specifically for the voluntary contraction. And gamma motor neuron is important for the tone of the muscle. So please remember, if they are asking about lower motor neuron lesion, lower motor neuron is gone, matlab alpha and gamma both are gone. That means the person will not be able to contract the muscle voluntarily, which is called as paralysis. But which paralysis? Will there be any tone? No, the gamma is also gone. No, gamma is also a lower motor neuron, that is also gone. So there will be lower motor neuron where you have flaccid paralysis. So yes, the flaccidity will be seen, hypotonia will be seen, depending on the damage, the level of damage of the gamma motor neuron. Fasciculation, fibrillation will be seen. Please remember, if you have low tone, there will be hyporeflexia or areflexia, which is going to be seen. Hyperreflexia is a phenomena in the upper motor neuron region, not in the lower motor neuron lesion. Yes, Dr. Sasha, accidental doctor, when you, yes, you, Ravi, you all are absolutely correct. So we have discussed this. Upper motor neuron where tone is going to be high, DTR is high, muscle atrophy will not be seen because the gamma is still active. Fasciculation, fibrillation will be not seen. Rather, we can see the Babinski sign positive, Babinski positive. Tone over here in the lower motor neuron lesion, tone is going to be lower, DTR is lower. On the other hand, you can see the muscle atrophy, disuse atrophy, and fasciculation, fibrillation. So, Babinski sign positive. If you strike the sole of the foot of a person like this in this direction, towards upward and towards medially, you should see the plantar flexion and the toes coming together. But if the patient is having upper motor neuron lesion, you're going to have the Babinski's positive, that is dorsiflexion and fanning of the toes. That means the toes will fall apart, right? So dorsiflexion of the thumb and fanning of the toes, which will be seen. चलो आगे बढ़ते हैं. Next, unsteady gait. Patient came to you with coordination difficulties, suggesting the potential involvement of cerebellar hemisphere involved. All right, in the planning, the coordination, lack of coordination means ataxia. Right, the cerebellum. Which of the following structure represents the most lateral part of the cerebellar hemisphere? What is lateral part? In middle, just remember, I have a diagram. I think yes, we have. See, there are three major parts. What are the three parts? In the middle, we have spinal cord in the body. So please remember, in the cerebellum also, we have spinal cord, that is spinocerebellum, that is vermis and paravermis together. Vermis and paravermis together. They are going to cause, this is like they're acting as a spinal cord, just remember that, right? And since the spinal cord is in the center, these are the ones which are going to help me out in the posture balance, because for the posture, I'm going to require the central muscles, right? Back muscles and the hip muscles, all these muscles will be required for the posture maintenance. So axial muscles or the proximal muscles will be supplied by this spinocerebellum. On the other hand, you have the oldest part, which is going to be over here. See, this is the vestibulocerebellum. It is the oldest, and oldest we call it as archi. Archaeology you must have heard of. So archi cerebellum. This is the flocculonodular lobe of the cerebellum, which is the oldest one. And whenever you have vestibule in the word, so that means it is important for the equilibrium and balance. Balance and equilibrium will be maintained by this vestibulocerebellum. All right. Now, the remaining part is the last one, that is acting as the hemisphere. Hemisphere, that is going to be your peripheral part. This is known as cerebrocerebellum. This is developed at the end of the evolution. That means it is recently developed. Recently means almost 100 years back, right? So it is the one which is going to be developed later in the evolution. So please remember, in us, in our human body, we do have very well developed cerebrocerebellum, right? And that is neocerebellum. Since it is developed, in the development, it is newer ones. So that's why it is called as neocerebellum, right? Neocerebellum or cerebrocerebellum. This is none other than your lateral hemisphere of the cerebellum. Okay, and this is important in the motor planning. Planning ke liye you require neocerebellum. Plus, we have as a animal, we do have the skills, fine skills, which is not seen in the other animals, right? So fine skill, the planning, programming, coordination, the fine skills will be mainly covered by this neocerebellum, or it will be taken care by the neocerebellum. Please remember, painting, writing, all these skills are present in us. Why? Because our neocerebellum is very well developed. So periphery mein new is periphery. Spinal cord is old, but not oldest. Old hai to we can call it as paleo. So please remember, spinal mein P is there, so it is called as paleocerebellum, right? Whatever question they have asked, you should know about it, that where the things lie and what is their function mainly. So distal part muscle is supplied by the peripheral part, because the distal muscles are in the periphery, yaad rakhna, and that's why it is going to be covered, or it will be controlled by the cerebrocerebellum, which is the outermost part of the cerebellum, neocerebellum. So what is the most lateral part? Cerebrocerebellum, easy. Vermis is in between. Flocculonodular lobe is below, right? It is not the hemisphere which is going to be containing there. All right. So option B is going to be there. This is the flocculonodular lobe. Archicerebellum, or the lowermost part, is called as the flocculonodular lobe. There is going to be a lobar distribution, which you are going to see in the anatomy, but the flocculonodular lobe in physiology will be called as vestibulocerebellum, because it is going to go towards the vestibular nuclei and controls the balance and equilibrium, right? Sure. Next, in the INI-CET, I guess, last year, they have asked about vestibulo-ocular reflex will be maintained by. It is none other than the flocculonodular lobe. Please remember, vestibulo aya, it is going to be related to flocculonodular lobe. All right, next. 39-year-old man, high altitude, is undergoing an evaluation of, all right, exchange parameters, all right, leading to enhanced release of carbon dioxide from the blood into the alveolar space or exhalation. Which of the following physiological principle best explain this observation? See, what is happening in his lung at the alveolar level. Alveolar layer means what? What is happening inside the lung. I told you there are going to be two effects which are going to be there. LLL in the lung, what happens? Loading of oxygen occurs. Loading of oxygen, that means the oxygen is going to get attached to the hemoglobin, right? And what we are going to do, this is going to be in the lungs, and we call it as Haldane's effect. And which shift it is going to cause in the OH-DC curve? It is going to cause left shift. On the other hand, if I talk about the Bohr's effect, what is the Bohr's effect? It is going to be seen in the rest of the tissues, not in the lung. It is going to cause release of oxygen, right? And over here, there will be release of carbon dioxide in the lung, okay? And it is called as Bohr's effect, right? And that is going to cause a right shift in the OH-DC curve, all right? Even if you remember this, you will be able to answer. Fick's law is important for the diffusion, but overall diffusion, it is not in the lung only, right? In the tissue also, the Fick's law will be working. So this cannot be the answer. Chloride shift specifically mentions in the vein, not in the lung, right? So that cannot be the answer. And they are talking about the lung. Oxygen binds to the hemoglobin means this literally means we're talking about loading of oxygen. So it is going to be the Haldane's effect. Haldane's effect, option B. Option B, you can see over here, there are two effects clearly shown. See what happens. CO2 which will be produced, which is going into the RBC, which will be bound to the hemoglobin, right? So from the oxyhemoglobin, the oxygen will be released, and this H plus ion will bind to the hemoglobin at the level of the tissues, right? The tissues are releasing this carbon dioxide, right? And the oxygen will be released. This is going to occur in the tissues, but in the lungs, what is going to happen? Suppose this is the alveoli, the lung is there. So this oxygen is going to come, because the oxygen concentration is more inside the lung, it is going to come into the blood vessels and going to go into the RBC, and the oxyhemoglobin will be formed. That means loading of the oxygen onto the hemoglobin, right? And there will be release of carbon dioxide towards the alveoli. So the left hand side, the Haldane effect is shown, and the right hand side, Haldane effect is shown, and left hand side, the Bohr's effect is shown. Okay. So this is Haldane's and Bohr's. Easy. L, 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 R, 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 R. All right. Next, a 68-year-old man with the history of chronic obstructive pulmonary disease. All right. So arterial blood gas analysis shows high proxemia despite normal ventilation. PFT reveals increased physiological dead space. Which of the following best explain this finding? COPD. What is going to happen in the COPD? The obstructive pulmonary disease, so there are going to be bronchitis also and emphysema. Mainly in the emphysema, the functional surface area decreases. Overall surface area increases of the alveoli, but the functional area decreases. So please remember, the alveolar dead space increases. There is no change in the anatomical dead space. Anatomical dead space remains the same. The major problem is going to come because of the alveolar dead space. What is the anatomical dead space and alveolar dead space? Zara batana. From generation number 0 to 16, you cannot exchange the air. Even the air is there into the airways, right? So this is known as the anatomical dead space, which is going to remain constant as 150 ml usually, right? And if we talk about this 350 ml, this 350 ml should be exchanged completely with the air. But since the patient is having, let's say, the emphysema and there is some bronchitis, right? Because of that, what is going to happen? Only, let's say, 300 ml of air will be exchanged and rest will not be exchanged. Unexchanged air is known as the dead space. Unexchanged air from generation number 17 to 23 will be called as the alveolar dead space. Dead space, unexchanged air. Alveolar dead space, near the alveoli, right? Or inside the alveoli. So anatomical dead space will not be increased. So this is not true. Decrease in the alveolar dead space. So that will be called as, that is going to cause a decrease in the physiological dead space. Now, physiological dead space is anatomical dead space. plus alveolar dead space, isn't it? So if I decrease the alveolar dead space, the total dead space should be decreased. Now over here, the physiological dead space has been increased, right? So this is not possible. Increase alveolar dead space, that is true, and increase alveolar oxygen. If the disease person start to have increase in the oxygen exchange, so then we require this disease more and more, right? So that is not true. The patient is there with the problem of dyspnea, so there will be lesser oxygen in the you can say arteries. So that is going to be because of the lesser exchange of the oxygen.